I need to tell you something that most people learn too late. A stroke does not begin the moment the face droops, or the arm goes weak, or the speech becomes slurred. Those are the signs of a stroke that has already happened. The arterial territory has already been cut off. The brain cells in that region have already begun dying at a rate of approximately 1.9 million neurons per minute. By the time those classic signs appear, the window for the most effective intervention is already counting down. What I want to talk to you about today is what happens before that moment. In the hours preceding a full stroke, in what clinicians call the prodromal period, the body sends signals that are almost universally present and almost universally missed. Not because they are subtle, not because they are ambiguous, because nobody has explained what they mean. Because most people who experience them rationalize them away, attribute them to tiredness or stress or something they ate, and go to sleep, and wake up either unable to move or do not wake up at all. I am Dr. David Miller. I have been practicing medicine for 15 years, and I built this channel on one principle. The information that saves lives in cardiovascular and cerebrovascular medicine is not complicated. It requires that the right people know it at the right time. Most of them do not. Subscribe to Dr. Miller right now and hit that like button. We are building a community of people who know what their body is telling them before the emergency happens rather than after. Every subscriber makes this channel more visible to the next person who needs it. Before I describe the warning signs, I need to explain what is actually happening inside the artery in the hours before a stroke. Because the mechanism is what makes the signs make sense, and understanding the mechanism is what creates the urgency to act rather than wait and see. The vast majority of strokes, approximately 87%, are ischemic strokes. Ischemic means caused by a blockage of blood flow rather than by bleeding. In an ischemic stroke, a portion of the brain is cut off from its blood supply. The cells in that territory begin dying within minutes. The blockage is caused by one of three things: a clot that forms on an atherosclerotic plaque in a cerebral or carotid artery, a plaque being a buildup of lipid and inflammatory material in the artery wall that narrows the vessel and creates a rough, irregular surface on which clots form, a clot that forms elsewhere in the body, most commonly in the heart, and travels through the circulation to lodge in a cerebral artery, or a small vessel deep in the brain that becomes completely occluded by the same vascular disease that affects larger vessels. In the hours before a major stroke caused by plaque-related clotting, something important and detectable often happens first. The plaque becomes unstable. A small piece of it breaks off, or the clot on its surface partially forms and then partially dissolves, releasing a fragment that travels downstream and temporarily blocks a small arterial branch before being broken down by the body's own clot-dissolving mechanisms. This temporary, self-resolving blockage is called a transient ischemic attack, a TIA, and it is the single most important warning the body can send before a major stroke. Depending on which artery is temporarily blocked and for how long, a TIA can produce symptoms that last seconds, minutes, or up to 24 hours. By definition, a TIA resolves completely. The function returns. The person feels fine afterward. And this is precisely why it is so dangerous. Because feeling fine afterward is what causes most people to decide it was nothing and not seek evaluation. The statistics on this are among the most alarming in all of medicine. Studies consistently show that approximately 10 to 15% of people who experience a TIA will have a full stroke within 3 months, with half of those strokes occurring within the first 48 hours after the TIA. The risk is highest in the first 24 to 48 hours and drops substantially if the TIA is evaluated and treated aggressively in that window. The evaluation and treatment of a TIA requires a hospital setting, imaging of the brain and carotid arteries, cardiac monitoring for atrial fibrillation, and anticoagulation or antiplatelet therapy initiated immediately. It is not a situation for calling your doctor's office in the morning. It is a situation for calling emergency services within minutes of the symptom appearing, even if the symptom has already resolved by the time you make the call. Let me tell you about a patient I will call Thomas. He was 71 years old. He had a history of hypertension managed with medication and a borderline cholesterol that his physician had decided did not yet require a statin. He had been doing reasonably well. On a Tuesday evening, while watching television, he noticed that the vision in his right eye went blurry suddenly. Not gradually, suddenly. As if a curtain had been drawn across the lower half of his visual field in that eye. It lasted approximately 3 minutes and then resolved completely. He told himself he needed to have his eyes checked. He mentioned it to his wife as an odd thing that had happened and went to bed. On Wednesday morning, he woke with a mild headache and what he described as a strange feeling on the left side of his face, a tingling that was not pain. It lasted perhaps 20 minutes and resolved. He took a painkiller for the headache and went about his day. On Thursday morning, 38 hours after the first episode, Thomas woke unable to move his left arm. His left leg was weak. His speech was slurred. His wife called emergency services. The CT scan in the emergency department showed a large ischemic infarct in the right middle cerebral artery territory. He spent 11 days in hospital and left with significant residual left-sided weakness that required months of rehabilitation. The episode on Tuesday evening was a TIA. It is called amaurosis fugax when it involves monocular visual loss, a temporary blockage of the ophthalmic artery, the artery that supplies the eye, which is a branch of the internal carotid artery, the same artery that supplies the hemisphere of the brain. Transient monocular visual loss is one of the most specific warning signs for impending carotid territory stroke that exists. The Wednesday morning facial tingling was a second TIA, involving the sensory cortex this time rather than the visual pathway. 2 warning signs in 24 hours, neither recognized for what it was. The stroke occurred on the 3rd day. Now I want to walk you through the specific prodromal signs that precede stroke in the hours to days before it occurs, because most people have heard of the FAST acronym: face drooping, arm weakness, speech difficulty, time to call emergency services, which describes the stroke itself. What they have not been told is what to look for before those signs appear. The first prodromal sign is sudden transient visual disturbance. This can take multiple forms: a sudden darkening or complete loss of vision in one eye, lasting seconds to minutes, which is the amaurosis fugax I described in Thomas's case; a sudden appearance of double vision that was not there before and is not explained by tiredness or alcohol; a sudden loss of vision in the same half of the visual field in both eyes simultaneously, which occurs when the occipital cortex at the back of the brain, which processes visual information, is transiently deprived of blood. Any sudden change in vision that was not there the moment before, that affects one or both eyes, that is not explained by a change in lighting or a known eye condition, and that resolves on its own within minutes or hours, is a TIA until proven otherwise. It requires emergency evaluation the same day, not an eye appointment, an emergency evaluation. The second prodromal sign is sudden transient weakness or numbness on one side of the body. The key word is sudden. Not the gradual stiffness of an arthritic joint warming up in the morning, not the tiredness of a muscle that has been overused, a sudden onset of weakness or numbness in the arm, the leg, or the face on one side of the body, appearing without obvious cause, lasting minutes to hours, and then resolving. The unilateral nature is the critical feature. When a cerebral hemisphere is transiently deprived of blood, the deficit appears on the opposite side of the body because the motor and sensory pathways cross in the brainstem. Left hemisphere TIA produces right-sided symptoms. Right hemisphere TIA produces left-sided symptoms. If someone tells you they suddenly could not lift their right arm for 5 minutes and then it was fine, or that the left side of their face went numb for 20 minutes and then returned to normal, that is a medical emergency that is presenting its business card before the main event. It requires emergency evaluation. The third prodromal sign is sudden severe headache of a new character. This is the sign most associated with hemorrhagic stroke, which is caused by bleeding rather than blockage. The headache of a hemorrhagic stroke is classically described as the worst headache of my life, a sudden thunderclap onset reaching maximum intensity within seconds, which is caused by blood entering the space around the brain under pressure. This is a 999 or 911 call immediately. No waiting to see if it improves, no painkiller and monitoring. A sudden, severe headache that is different in character and intensity from any headache the person has experienced before, particularly when accompanied by neck stiffness, light sensitivity, or any neurological symptom, is an emergency. But there is a subtler headache pattern that precedes ischemic stroke and is not the thunderclap variety. In the hours before a major ischemic stroke, many patients retrospectively report an unusual headache, not severe, not incapacitating, but different. Occipital, meaning at the back of the head, or unilateral, on one side, combined with a vague sense of not feeling right that is difficult to articulate. This softer headache, in combination with any of the other prodromal signs I am describing, elevates the concern significantly. Isolated headache is not a stroke sign. Headache combined with visual changes, or combined with unilateral weakness, or combined with speech difficulty, is a constellation that requires immediate evaluation regardless of how mild the individual components are. Subscribe to Dr. Miller and hit the like button. What I am describing, the clinical presentation of a TIA and the prodromal signs of impending stroke, is the material taught in neurology and emergency medicine training. The gap is that patients are taught to recognize stroke once it has happened through the FAST acronym, but are almost never taught to recognize what precedes it. The window for prevention closes in hours. This channel exists to give you that knowledge while the window is still open. Hit subscribe. Every subscriber means the next person experiencing a TIA tonight has a chance of recognizing it before it becomes a stroke. The fourth prodromal sign is sudden difficulty with speech or language. In a TIA, this may appear as a transient difficulty finding words in the middle of a normal conversation, a brief inability to say what you intended to say despite knowing what you meant, or a brief period in which spoken or written language seemed harder to understand than normal. The person may describe it afterward as a brain fog or a mental blankness that was sharper and more sudden than anything they had experienced before. If someone in your presence suddenly begins having trouble speaking fluently, struggles to complete sentences they were constructing normally moments before, or appears briefly confused about language in a way that resolves within minutes, that is a TIA presentation that requires an emergency call. The fifth prodromal sign is sudden loss of balance or coordination, particularly when it appears with any of the other signs. The cerebellum and brainstem, which coordinate balance and the fine control of movement, are supplied by the vertebro-basilar arterial system, which is separate from the carotid system that supplies the cerebral hemispheres. TIAs in the vertebro-basilar territory can produce sudden onset vertigo, loss of balance, difficulty walking, or double vision, often without the unilateral limb weakness or speech difficulty that characterizes carotid territory TIAs. These posterior circulation TIAs are particularly dangerous because their symptoms overlap with benign conditions such as inner ear problems and are frequently dismissed or misdiagnosed. Sudden onset vertigo in a person over 60 with vascular risk factors is a vertebro-basilar TIA until proven otherwise. It is not the same as the positional vertigo that takes seconds to develop when lying down. It is sudden, severe, and often accompanied by nausea and a feeling that the room is spinning regardless of position. The sixth sign is not acute in the way the others are. It is a behavioral and physiological pattern in the hours to days before a stroke that family members sometimes notice before the person themselves does. An unusual fatigue that is deeper than normal, a withdrawal from conversation or activity that is out of character, a vagueness or mild confusion that the person cannot explain, a sleep that is heavier than normal. In the hours before the infarct, as the affected arterial territory is progressively compromised, cerebral blood flow in the region may be reduced without being completely blocked. Neurons in the penumbra, the zone surrounding the at-risk tissue, are functioning poorly. The cognitive and behavioral consequences of this reduced perfusion can manifest subtly as the signs I described. Family members who know the person well are often better positioned to notice these changes than the person experiencing them. Now I want to be direct about what to do with this information because the knowledge is only useful if the action is clear. If you or someone in your presence experiences any of the following, call emergency services immediately and do not drive yourself to the hospital. Do not wait to see if it improves. Do not call the doctor's office and leave a message. Call emergency services. The signs that require this response are any sudden change in vision in one or both eyes, any sudden weakness or numbness on one side of the body, regardless of how brief, any sudden difficulty with speech or language, any sudden loss of balance or coordination accompanied by any other neurological symptom, any sudden severe headache that is different from previous headaches in intensity or character. The word sudden is doing critical work in every one of these descriptions. Gradual onset over hours is a different clinical picture. Sudden onset within seconds to minutes is the signature of a vascular event. If the symptom has resolved by the time you or the person is evaluated, tell the evaluating physician exactly what happened, including the time of onset, the duration, and the specific character of the symptom. Do not minimize it because it resolved. Resolution is not reassurance. Resolution is the definition of a TIA. The evaluation required after a TIA includes brain imaging, imaging of the carotid arteries, cardiac monitoring for at least 24 hours to detect atrial fibrillation, blood pressure assessment, glucose and lipid testing, and initiation of secondary prevention therapy. This evaluation, performed within 24 hours of a TIA, has been shown in multiple studies to reduce the subsequent stroke risk by up to 80%. 80%. Thomas's stroke was not inevitable. If his Tuesday evening visual episode had been recognized as a TIA and he had gone to an emergency department that night, the arterial territory could have been imaged, the unstable plaque identified, and antiplatelet therapy initiated before the clot that caused Thursday's stroke had the opportunity to form. His stroke was preventable. The warning was there. The knowledge was not. How old are you? Write it in the comments right now. I want to see the age range of this audience because it determines everything I focus on next. If most of you are in your 60s, I want to go deeper on the modifiable risk factors for stroke and the specific blood pressure, cholesterol, and glucose targets that have the strongest evidence for stroke prevention because the numbers matter and the targets have evolved. If many of you are in your 70s, I want to address what the research shows about atrial fibrillation as a stroke risk factor in that age group specifically, because the absolute risk is substantially higher, and the implications for anticoagulation therapy are significant. The knowledge I have just given you is the kind that belongs in every household, not because everyone will have a stroke, because the people who will have one almost always have a TIA first. And the TIA is the window. It is the moment when the outcome is still changeable. When the clot can be dissolved, the plaque can be stabilized, the artery can be imaged and managed before the territory it supplies goes dark. That window is narrow. It is measured in hours, but it is there. And now you know how to recognize it when it opens. I am Dr. David Miller, and I have spent 15 years watching preventable strokes occur in people who experienced TIAs they did not recognize, or who recognized something was wrong but waited to see if it would pass. It passed. And then something worse came. Share this video with the people in your life who are over 60, who have high blood pressure, who have had any of the symptoms I described and dismiss them, not because you want to frighten them, because the warning they receive from this video is the warning they did not receive from their physician. Subscribe to Dr. Miller. Hit the like button. The healthcare system treats strokes after they happen with enormous cost and incomplete recovery. I profit from you recognizing the warning before that point and acting in the window when something can still be done. Subscribe if that difference matters to you. This content is educational in nature and does not constitute personalized medical advice. If you experience any sudden neurological symptom, including visual changes, limb weakness, speech difficulty, severe headache, or loss of balance, call emergency services immediately. Do not use this video as a substitute for emergency evaluation. Time is brain tissue, and every minute of delay in a stroke or TIA matters.